Hello everyone, my name is Loretta Odro and I will be presenting on a musculoskeletal case study on behalf of Group 3. So this is our case study. Karina is a 45-year-old self-identified female, full-time right-handed male career, and she's also taking administrative courses online. She's in the office for a routine physical. The last time she was seen in the office was about a year ago. Her last A1C or hemoglobin A1C was 6.5%, and she reports neck pain after long days at work. She has been having trouble getting a restful night's sleep, and she often wakes up because her right hand feels numb and painful. Sometimes her right arm hurts. Karina is concerned because it seems she also has trouble opening jars. So this is additional pertinent information with regards to Karina's case. And since we're simulating an office visit, we came up with a chief complaint, which reads, I have been having neck pain after long days at work, but now I am having trouble sleeping because of pain and numbness in my right hand and sometimes my right arm. I am concerned now because I am having trouble opening jars. Her past medical history includes hypertension and type 2 diabetes, which she was diagnosed with in 2019. She has no known allergies, and she takes lisinopril 20 milligrams daily to manage her hypertension and metformin 750 milligrams twice a day to manage her diabetes. So knowing what we know now about Karina's history, we decided to start with discussion question one, which asks, what further questions do you want to ask your patient? And to gather more data about this patient's history and symptoms, we decided to go ahead and ask her when her symptoms started. Is the pain or numbness and tingling occurring in the entire right hand, or is it particularly felt in specific areas like her thumb, index finger, or ring finger? Does she have any weaknesses? Example, is she dropping things since she's having trouble opening jars? Does she have any swelling? We would also like to know how long the pain or numbness is lasting when it occurs. So the duration. And also what kind of pain she's experiencing. Is it throbbing? Is it achy? Is it dull? Is it sharp? We would like to know the qualities of that pain. We would also like to know what triggers the pain, if there are any triggers. So anything that triggers it or anything that alleviates the pain, like shaking the hands or holding or running the hand under warm water. Does that improve her symptoms? Any aggravating factors such as driving, holding the telephone, using vibrating tools, or typing, since she's also in administrative school, so we assume she's also doing a lot of typing. Does the pain also occur at any time besides during the night? Because she does report that she only experiences the pain at nighttime, but we would like to know if the pain is occurring any other time besides the nighttime. And obviously, if it's waking her up at night, if it's occurring any time besides nighttime, we would want to know if it's interfering with her daily activity as well. On a scale of 1 to 10, we would like to know how she would rate her pain. And we would also like to know if she's taking any over-the-counter medications to manage her symptoms, and if any of them have helped, if she is taking any over-the-counter medications. So now we move on to her physical examination and a review of her systems. For her vital signs, her blood pressure was 132/72. Heart rate is 72. Respirations are 16. Her height is 67 inches, which is 5 feet 5 inches. And her weight is 195 pounds, which is about 88.4 kilograms. For her neck, assessment of her neck, her range of motion in the neck is limited with rotation to the right. And in assessing her musculoskeletal system, her muscle strength is 5 out of 5 and symmetric in all muscle groups. She has full range of motion in all of her extremities as well. Neurologically, her deep tendon reflexes are 2/4, which is normal. She has no atrophy in her thenar muscle, but she does test positive for the Tenel sign at the right wrist. She has no decrease in sensation in fingers or the bottom of her feet. So that brings us to discussion question number 2, which is How do you differentiate between radiculopathy and peripheral nerve compression or neuropathy? So radiculopathy is a pathologic process affecting the nerve root. The causes of radiculopathy can be divided into compressive and non-degenerative etiologies, but most radiculopathies arise from nerve root compression according to Kuthari 2023. Peripheral nerve compression, on the other hand, occurs when there is pressure on nerves in the peripheral nervous system. These nerves connect to parts of the body, like our hands and feet, and that which are farther away from the central nervous system, like the brain and the spine. And so the nerves in the arms and legs can become compressed due to narrowing of the passageways or from tumors or other diseases. Carpal tunnel syndrome is an example of a compressed nerve, according to Cleveland Clinic 2021. So in short, radiculopathy is caused by the pinching of the nerve roots in the spinal column, whereas neuropathy is a sign of damage or malfunction of the peripheral nerves. So based on what we know now about Karina's case, the differential diagnosis that we came up with were cervical radiculopathy, which has a ICD-10 code of M54.12, brachial plexus syndromes, which has an ICD code of G54.0, and then the median neuropathy in the forearm with an ICD code of G56.91. So this brings us to discussion question number 3, which is, what are your differential diagnoses? Name at least 3. So we've listed them, but we kind of explained a little bit what the 3 differential diagnoses that we came up with were, just a little bit of information about it. So cervical radiculopathy is a clinical condition due to a pathologic process affecting the nerve root that may cause the neck, shoulder, or arm to hurt. Muscle weakness and or sensory symptoms may also occur. Compressive cervical radiculopathy is recognized to be a common source of arm pain with or without sensory and motor dysfunction, according to Kuthari 2023. Then with brachial plexus syndrome, so the brachial plexus itself is a network of nerve fusions and divisions that originate from the cervical and apothoracic nerve roots, and they terminate as named nerves that innervate the muscles in the skin of the shoulder and arm. So the nerve roots from C5 through T1 contribute to the brachial plexus, according to Kuthari 2023. Symptoms depend on where along the length of the brachial plexus the injury or trauma has occurred, and how severe they are, according to Johns Hopkins Medicine 2024. So if the nerves that originate lower in the brachial plexus are injured, the arm, the wrist, the hand are affected. Common symptoms of brachial plexus syndrome also include numbness or loss of feeling in the hand or arm, an inability to control or move the shoulder, arm, wrist, or hand, and also a burning, stinging, or severe sudden pain in the shoulder, arm, and or hand, according to Johns Hopkins Medicine 2024. Now, median neuropathy in the forearm is more related to carpal tunnel and may occur in the forearm. It's the median neuropathy proximal to the carpal tunnel may occur in the forearm, where the nerve passes through the pronatus muscle. Patients may present with forearm pain and sensory loss involving the entire lateral palm. Features that favor a forearm localization include the findings of sensory loss over the thinner eminence and weakness of more proximal median innervated muscles. So the thumb flexion, wrist flexion, arm pronation, according to Kuthari 2023. And this will present obviously as aching pain in the affected area. So based on subjective and objective data that we've gathered from this case, we said our most likely diagnosis will be carpal tunnel syndrome with an ICD-10 code of 56.0. But we think that it's also related to cervical radiculopathy because of how it started. The pain, numbness in the hand started with neck pain. And so our most likely diagnosis is carpal tunnel syndrome, most likely related to cervical radiculopathy. And that brings us to discussion question number 4, which is, what is your diagnosis for today? Well, our diagnosis is carpal tunnel syndrome related to cervical radiculopathy, most likely related to cervical radiculopathy. Carpal tunnel syndrome, or CTS, refers to the complex symptoms and signs brought on by compression of the median nerve as it travels through the carpal tunnel, according to Kothari 2023. The peripheral nerve pathway that leads to the median nerve in the carpal tunnel begins in the cervical spine. Symptoms include weakness when gripping objects with one or both hands, which Karina exhibits, pain or numbness in one or both hands, which she also exhibits, pain or numbness that is worse at night and interrupting sleep, which she clearly exhibits as well, swollen feeling the fingers and burning or tingling in the fingers, especially the thumb and the index and middle fingers, according to Johns Hopkins 2024. This is also worth knowing because we came across this during our research, that cervical radiculopathy is a group of signs and symptoms caused by cervical root dysfunction. So patients with this condition may also have carpal tunnel syndrome, which is caused by compression of the median nerve in the carpal tunnel, like we know now. So this coexisting condition is referred to as double crush syndrome, which is explained by proximal disruption in the exoplasmic flow that may result in nerve dysfunction, according to Chimori et al. 2023. So we thought that was an interesting finding and was worth noting. So diagnostics for carpal tunnel syndrome. It's obvious that during the assessment, the patient had a positive Tinel sign, which is often a test that is done to assess for carpal tunnel syndrome. So the Tinel sign test is often used to diagnose carpal tunnel syndrome. A positive Tinel sign is the presence of a tingling feeling when the skin over the affected nerve is tapped. So in CTS, the affected nerve is the median nerve at the wrist, according to Cleveland Clinic 2022. So this brings us to discussion question number 5, which is what additional diagnostic tests would you order, if any? Provide clinical-based evidence for your decision. So the diagnosis of carpal tunnel syndrome is usually based on symptoms and physical examination findings, which include diminished sensation in the thumb and the index, middle, and half of the ring finger, as well as thumb weakness, according to Walter 2022. So specialized tests, including electrodiagnostic testing that measure both nerve and muscle functions, including nerve conduction studies, and electromyography, can be ordered to confirm the diagnosis of carpal tunnel syndrome. These electrodiagnostic tests include nerve conduction studies as well as electromyography. So nerve conduction studies is the use of electrical impulses to assess nerve damage. Any delay in latency across the wrist when performing the nerve conduction studies confirms the diagnosis of carpal tunnel syndrome, according to Hollier 2021. And then the other electrophysical conduction that can be done is the electromyography test, and that is typically considered if the nerve conduction studies happens to be negative. So electromyography is a diagnostic test that evaluates the health and function of the skeletal muscles and the nerves that controls them, according to Cleveland Clinic 2023. Some studies also suggest using ultrasound imaging as it may be useful and also is a non-invasive test to diagnose carpal tunnel syndrome, according to Walter 2022. These tests, especially the nerve conduction studies and the electromyography test, have been the American Association of Neuromuscular and Electrodiagnostic Medicine have confirmed that these two tests are determined to be the most sensitive and specific in diagnosing conditions like CTS, according to Sino et al. 2018. So treatment plan for carpal tunnel syndrome involve pharmacologic and non-pharmacologic measures, surgical intervention, obviously patient education. It may be necessary to have some consultation and referrals, and also education about follow-up. And that brings us to discussion question number 6, which is, what is your treatment plan, including medications, patient education, and guidelines for patients to call your office in a return for office visit? So with non-pharmacologic management, we believe that Karina would benefit from a lifestyle modification that involves some changes in her diet and physical activity for effective management of diabetes, because with non-pharmacologic measures, it's essential to correct the underlying disorder, which frequently causes the carpal tunnel syndrome. In her case, she has diabetes. And so some studies show that frequent causes of carpal tunnel syndrome does not only involve repetitive motions of the wrist, but also endocrine disorders such as obesity and diabetes, according to Zimmerman et al. 2022. So it's essential to instruct the patient to follow a low-carb diet to help, and to make some necessary lifestyle modifications to help lower her blood glucose level. She may another non-pharmacologic management will be splinting of the wrist in neutral positions with the fingers free to kind of help keep the wrist in position so it's not moving so much. Meanwhile, the fingers are free to move around. Pharmacologic management, according to Hollier 2021, include the use of NSAID agents in doses that are sufficient for anti-inflammatory effect. So when we think about NSAIDs, we know our ibuprofens, Advils, Motrins, and all that. Usually, NSAIDs, non-steroidal anti-inflammatories, help with the pain and the swelling, according to Jackson 2024, and as we know also as nurses. Intermediate acting corticosteroid injection may also help. A maximum of 3 injections in 2 to 3 month intervals have been known to help. Steroid injection into the affected area may also result in modest relief of symptoms, as Walter 2022 discusses. And also recent research has shown that there's significant improvement in the outcomes in pain and function and remission of nocturnal paresthesia with a single local corticosteroid injection compared to night splints at 1, 3, and 6 month follow-up, according to Jackson 2024. We can also do injection of anesthetic and hydrocortisone shots, especially for people who are pregnant. We know that our patient is not pregnant because it doesn't say in the case study, but it was a good finding for pregnant people who may be experiencing carpal tunnel syndrome. There has been a positive response to injection that may signal a higher likelihood of benefit of surgery also. Local injection of anesthetic and hydrocortisone is useful during pregnancy. Again, so if this patient were to be pregnant, this would be a good treatment, pharmacologic treatment or management for her. And also, last but not the least, because of her diabetes, the case study doesn't say much about management of her diabetes, but we may need to increase her metformin dose to help her better manage her A1C. Maybe an increase from 750 twice daily to 1,000 milligrams twice daily could help. It is worth noting that combined non-surgical and pharmacologic interventions may be the most effective. Mainstay treatments for mild to moderate carpal tunnel syndrome include night splinting for 12 weeks and then local corticosteroid injection, according to Jackson 2024. Now, surgical intervention, some people may need surgery to fix their carpal tunnel syndrome, depending on how severe it is. Surgical decompression of the carpal tunnel with release of the transverse carpal ligament and debridement may be necessary or may be indicated for some patients. There has been strong evidence that indicates that surgical treatment of CTS or carpal tunnel syndrome results in better functional improvements at 1 year compared to non-operative treatment, according to Jackson 2024. Some patient education to give to Miss Karina would be to avoid aggravating factors, that is avoiding having frequent rest periods when repetitive wrist motions have been performed, and also to limit full extension and flexion of the wrist, to decrease heavy work activities, and to avoid repetitive movements of the wrist. If splinting of the wrist is initiated or is being done, she may need to wear her splint for about 4 to 12 weeks, wear it mostly at night, and then she may wear it during the day for activities that aggravate the condition. So this is discussion question number 6 continued. In terms of consultation and referral for carpal tunnel syndrome. So Miss Karina may need to see a surgeon depending on the severity or the persistence of her symptoms. If conservative therapy does not help. Referral to a certified hand specialist to provide patients with specialized range of motion wrist exercises may be necessary. There's no evidence that supports multiple trials of injection. However, surgery should be considered for those with refractory or recurrent symptoms. Therefore, surgery should be considered for those with refractory or recurrent conditions or symptoms. Those with moderate to severe disease benefit also early from surgery. And then for follow-up, in order to evaluate the effectiveness of the conservative therapy, that is using splints, NSAIDs, and cortisone injections, Miss Karina or patient may need to come for a post-operative evaluation by the surgeon. So follow up with the hand surgeon if symptoms do not improve after 6 weeks of consultation treatment of the constant numbness and atrophy of the muscle is going to be essential for patients to be able to follow up if these symptoms are not being alleviated after treatment. In most appropriately selected patients, surgery improves the symptoms of the carpal tunnel syndrome. So it depends on what's working for the patient, whether it's just simple conservative therapy or surgery. Whatever treatment plan they go for, whatever treatment intervention, surgery or pharmacological measures, they will still need to follow up with their providers to be reevaluated. And then a patient also needs to call the office or go to the nearest emergency department if she has worsening symptoms of her nerve compression, such as numbness or atrophy in the thumb muscle and other parts of the hand. Here are a list of references for our presentation.